diarrhea in North India, challenges in management. And I see only two challenges. One is the diagnostic challenge. When you are faced with a patient with chronic diarrhea, what is the cause of that diarrhea? And that is all clinical medicine, friends, I am telling you. And the other is a bigger challenge. Friends, we've been hearing about bans on films, bans on beef, etc., etc. I'll tell you, if we ban acute diarrhea is present for less than 2 weeks. So what are the common causes of this problem worldwide and in India? And friends, about 3 to 5% of our population is having chronic diarrhea, of which the commonest is the functional type of diarrhea, the irritable bowel syndrome. And that is one of the commonest diagnoses you may be seeing in your clinical practice as well. But then we have conditions like celiac disease, the tropical flu, parasitic infections, the lactose intolerance, tuberculosis, malabsorption, inflammatory bowel disease, etc., etc. And we should not forget, because many a times in my clinic, a patient has come from various physicians and ultimately it turned out to be nothing but a thyrotoxicosis causing diarrhea. So we must remember the diabetic diarrhea, the thyrotoxic diarrhea, and diarrhea related to Addison's disease. And a good history taking is always important, because drug history and drugs related causing diarrhea is also a very important cause of diarrhea which is not settling down. And once you have a patient with diarrhea, we must decide, and that is a very important point, is it a diarrhea coming from the small intestine or from the large intestine, or is it a pancreatic diarrhea, which is again something which we need not forget. So the diagnostic approach is answering just a few questions, maybe 4 or 5. The first question, most important, is this diarrhea functional or organic? The second question is the diarrhea of the small bowel type or the large bowel type? Third question is the diarrhea associated with malabsorption? And the last 2 points may be, overlapping. Is it painful or painless, and inflammatory or non-inflammatory? In fact, most of the inflammatory diarrheas are painful in most instances. So the last 2 points have got some degree of overlap. And therefore, let's come to the true clinical medicine. What are the important points of differentiating a functional diarrhea versus an organic diarrhea? One is, if you get a patient who's been having diarrhea for 10 years and is looking healthy, clearly it must be a functional diarrhea. Constitutional symptoms in functional diarrhea are hardly present. Weight loss is not there, appetite is normal, and one very important point, they have 5, 6, 10 diarrheas during the daytime, but once they go to sleep, they get up in the morning without passing through a single time at night. And this is a very important question, friends. Ask for nocturnal diarrhea. If nocturnal diarrhea is not present, long duration and the other features, please suspect functional diarrhea. And gastrocolic reflex. This is a very common symptom in clinical practice. Khana khane ke baad, I have to go to the toilet. This is an exaggerated gastrocolic reflex which is much more common in functional diarrhea. However, patients with ulcerative colitis, etc., who have got proctitis, can also have it. So it is not a truly specific symptom for functional disease. And anxiety symptoms are clearly more common in functional diarrhea. If you compare that with organic diarrhea, shorter duration, more marked constitutional symptoms, weight loss, appetite are all affected, and nocturnal diarrhea will be present. So in nocturnal diarrhea is an important feature. So that's about the functional versus organic. Now, how do we distinguish between small bowel diarrhea and the large bowel diarrhea? First are the number of stool spots. Less than 4 is small bowel, but they are large volume diarrheas and associated usually with borborygmi or the gurgling sound in the abdomen. Characteristics of the stool, you don't often see these days, frothy, greasy stools, because patients are being diagnosed early. There is no blood, no mucus, no pus, and no tenesmus in patients with small bowel diarrhea. So they just have diarrhea without too much of abdominal pain, and the diarrhea is large in volume associated with barbaric pain. Whereas in the large bowel diarrhea, they'll pass small amount of stools, but more frequent stools, and there may be presence of blood, mucus, pus, and tenesmus is an important feature. If you have a patient with tenesmus, certainly consider large bowel. So small bowel diarrhea, then, if you have, consider whether that is associated with malabsorption or without malabsorption. And with malabsorption, the features will be of the characteristics of the stool, patient with weight loss, anemia, and signs of nutritional deficiency. And the common examples of malabsorption in India are celiac disease, tropical flu, and so on and so forth. On the other hand, there are a number of causes of small bowel diarrhea where malabsorption is not present. So they have small bowel diarrhea without weight loss, without nutritional deficiencies, and some of the examples given here are bile acid diarrhea, where we use cholestyramine and sometimes give a sort of a trial of therapy also, because bile acid diarrhea is very difficult to prove. Secretory diarrheas and lactose intolerance, which is not an uncommon condition in India. So these are the conditions to consider. When you are considering large bowel diarrhea again, functional, irritable bowel syndrome and functional diarrheas, I will not go into details of that, but suffice to say that Room 3 criteria is used for this. Organic diarrhea can be there with blood or without blood. With blood, it will be inflammatory bowel disease, tuberculosis, tumors, etc. But there will be patients with large bowel diarrhea without any blood, and drugs and microscopic colitis should be considered, and biopsy, even if it is looking normal, from the rectum or sigmoid has to be done. Third point was, is the diarrhea due to inflammatory disease or non-inflammatory disease, and the features of inflammation if present, such as fever, constitutional symptoms, and joint pains are all pointers towards inflammatory diarrhea. And some of the examples of inflammatory and non-inflammatory type of diarrhea have been shown here. Now, painful and painless diarrhea, and again they are similar to the inflammatory. As I pointed out, most of the inflammatory diarrhea will have abdominal pain, although not necessarily. And once you have taken a proper history, one should be able to come to certain conclusions as to what is your provisional diagnosis. And subsequent tests should be really aimed to prove that condition rather than doing a whole range of screening tests. However, there will be patients where clear clues have not been provided and one has to do screening tests. And the screening tests are the complete hemogram, which gives us a lot of information and is a simple test. Similarly, liver function test is a very useful test to perform. And a stool examination. Now, this is something which is again a sort of a dying art. Stool examination, our good old physicians in the past used to ask the patients to bring their stool, and they would inspect the stool. It was a very good practice, but now neither do the patients want to bring their stool, nor do we have the time or the inclination to examine that or inspect that stool. So inspection is a dying art. Fecal tract analysis is also down the drain at the moment. Well, most important is the special staining for parasites and routine examination of the stool for ova and cysts has poor sensitivity. At least 3 specimens must be tested. And special staining has to be done for giardia and some of the other causes of parasites causing chronic diarrhea like Isospora, Cryptosporidium, Cyclospora, we are seeing a lot of patients with immunodeficiency, HIV, etc. And these are the organisms which we should be looking for in such patients having chronic diarrhea. Endoscopy in patients with chronic diarrhea is important, and we know the importance of that in patients with celiac disease, where you see the scalloping of the duodenal folds and biopsy shows villus atrophy, but presence of aphthous ulceration, mucosal edema, cobblestoning, luminal narrowing are all pointers towards Crohn's disease. Small, diffuse, white, punctate lesions are pointed towards lymphangiectasia. And remember, whenever you get an endoscopic procedure done, please request for biopsy as well. And this is a classical example of the scalloping of the duodenal folds, which we see in patients with celiac disease. Sometimes we are doing endoscopy for some other reason, and when we see this appearance, we always take a biopsy from there in order to make sure that there is no villus atrophy, and usually they are positive. If suspected to have large bowel diarrhea, sigmoidoscopy or colonoscopy is important. And on the left-hand side here, you see this feature in a patient who has features of chronic diarrhea. Again, biopsy needs to be taken because this diagnosis of microscopic colitis also needs to be considered. But functional bowel disease is clearly one of the most common diagnoses. On the other hand, you see ulcerations, and this is a patient with ulcerative colitis, but ulcers can also be present in Crohn's disease, tuberculosis, radiation-induced injury, etc. What is the role of imaging? Because very commonly we keep on doing the barium follow-through studies. Now, that is not encouraged now. In fact, you must decide as to why you are trying to do the imaging at all. Well, pancreatic disease, if you are suspecting, imaging is important. And to identify alterations that predispose to bacterial overgrowth. Bacterial overgrowth is also an important cause which needs to be considered. Presence of diverticula, stagnant loops of intestine, intestinal hypomotility, dilatation seen in patients with scleroderma, for example, intestinal fistula and tumors, and patients who have got ulcerations and strictures, such as what you see in tuberculosis and Crohn's disease. So, routine use of barium follow-through is discouraged. If you really want to study the small bowel now, it is better to do a CT enterography if you have, availability of that test at your place. Treatment, once you've done all these tests, you clearly have come to a diagnosis, and the treatment then is assessment of nutritional status, supplementation, providing the hematinics which are required, and then treatment of the specific condition, such as gluten-free diet with celiac disease, lactose intolerance, avoidance of milk, tuberculosis, antitubercular, and so on and so forth. Now let us look at what are the causes of malabsorption in India, because I would like to talk a little bit about celiac disease. Earlier, the commonest cause used to be tropical sprue, but now it is celiac disease as number one, and all the other causes are also there. But celiac disease in particular, I think, needs to be emphasized. This is a study from North India and looking at the etiological spectrum of patients with malabsorption, and you see here the majority of 40% plus patients had evidence of celiac disease, whereas 16% of the patients had giardia and 12% of the patients had tropical sprue. Now, if you look at studies from southern part of India as opposed to northern India, you may find a somewhat higher prevalence of tropical sprue over there. But we in North India certainly have to consider celiac disease. If we look at the prevalence in North India, well, this is the first study, is a study from Ludhiana itself. 1 in 310 children in Punjab having celiac disease. And this is a study from Dr. Sood from GMC. Haryana study 1 in 96. School-going children in Chandigarh 1 in 120. So what does all that mean? That we are dealing with a condition which is very common. And we estimate the prevalence all over India, then there must be about 5 to 8 million cases in this country of celiac disease. However, only a few thousand of this has been diagnosed, and therefore we are clearly missing out on a large number of patients who have got celiac disease, and therefore we need to aim to detect and treat the remaining population. What are the manifestations where we should suspect celiac disease? Well, the commonest are clearly the GI symptoms, the chronic diarrhea, malabsorption, abdominal distension, and weight loss. However, some of the important other pointers, and this is the group I would like to emphasize. Everybody probably would consider celiac in a patient with chronic diarrhea and malabsorption. However, if you have a patient with persistently elevated SGOT, SGPT, which does not have any other cause, please consider celiac disease because 20% of these patients present like that. Short-statured patients, patients with delayed puberty, all of them should be investigated for celiac. Patients with unexplained iron deficiency anemia, celiac disease again very common. Recurrent fetal loss and infertility in female patients, and the gynecologist should be aware of this and look for celiac disease. And other diseases where there is a high risk for celiac is type 1 diabetes, autoimmune endocrinopathies, and first and second degree relatives of patients, they have a very high prevalence. Other conditions where celiac can often present as what you think is irritable bowel. They may be mimicking autoimmune disease, and peripheral neuropathy and cerebellar ataxia are another two conditions where you do not find a cause. Please look for celiac disease. This is a study from AIIMS, and this is looking at the mode of presentation of patients with celiac disease. Well, almost 45% of the patients presented with chronic diarrhea, refractory anemia, and this is again 17.4%. So anemic patients always consider celiac disease. Patient with short stature, 19%. Metabolic bone disease, 4.6%. And interestingly, cirrhosis and portal hypertension, 6%. Now, this is certainly a little skewed because in AIIMS, they look for each and every patient with cirrhosis of the liver, will get a liver duodenal biopsy and investigation of celiac disease. But they are right, and therefore, there must be a large number of cirrhotics due to celiac disease which are not being really diagnosed, and therefore, they are missing out on the treatment. And therefore, this is another area we should be aware of. And again, patients go to the obstetrician and they have multiple problems, and therefore, so the awareness, the patient can really go to any of these specialists or internists, gastroenterologists, hepatologists, all they can. So the message is clearly all doctors must be aware of this condition and have a low threshold for suspecting and diagnosing celiac disease. So who should be investigated? Well, clearly, if you have features of celiac disease, they are clearly candidates for investigation. And patients with conditions which are associated with celiac disease. And I've already talked about that. And also remember patients who have got selective IgA deficiency. First degree relatives of patients with celiac disease because they have 4 to 12-fold increased risk. Therefore, it is not only the patient, please screen the family also, the first degree relatives. How do we diagnose? Well, serology is the most practical way of looking at it. Previously, anti-gliadin antibodies were used, and you can see they had a relatively lower sensitivity and specificity compared to the serological tests we are now doing. And the most common serological test is IgA anti-TTG, which is a high specificity and sensitivity. And anti-endomysial antibodies, again with a very high specificity. So these are the two antibodies we should really be concentrating on. Now, if you suspect the celiac disease and get a negative serology, please do this IgA deficiency. So check the IgA level, because the test may be negative because the IgA level of the patient is low, and therefore these patients should again be investigated in a different manner. So the diagnosis, and I will not repeat that, it needs the two antibodies, anti-TTG and the anti-endomysial antibody of the IgA type, and this is another gliadin antipeptide now which is being introduced. Plus you need the small bowel biopsy and HLA testing. This is a high negative predictive value. There are lots of patients who will refuse endoscopy biopsy. So if you have a high suspicion, do the HLA-DQ2 or DQ8, and if you have a negative test, then the chances of celiac disease is very low. On the other hand, if you have a positive test, that becomes useful. So the diagnostic criteria as proposed by the European Pediatric Society is this: symptoms plus serological test positivity plus small bowel biopsy. So this is the standard. I think everybody will agree with that. Now, what if we do not have a patient? We have a patient rather who does not want an endoscopy and a biopsy. Well, symptoms, a high positive anti-TTG, and do the HLA-DQ2 or DQ8. If positive, accepted, they can be put on the gluten-free diet. Diagnosis is finally confirmed when antibody levels decline on gluten-free diet. So that is one of the key issues. Once you put them on diet and the TTG antibody level comes down, so that's very good there, and you have proven the disease. Management, you all know, is lifelong gluten-free diet. Whenever I have a patient, they say, "Zindagi bhar chhodni padegi," and that is very important. It means a lot, because you have to leave this roti, parathe, amritsari, naan and everything for the rest of your life. Correct the nutritional deficiencies and keep the patient on long-term follow-up. And what you need is a skilled dietitian, because there are lots of other substances, not just wheat, rye, barley, etc., but lots of other substances. Women apply this lipstick, and there is a small quantity of gluten in the lipstick also. And there are lots of other substances, various chutneys, sauces, this, that, which have got gluten, and we can be taking it inadvertently. So, lifelong elimination of wheat, rye, barley. Clinical improvement occurs within weeks. Meat, dairy products, fruits, vegetables can all be given without any problem whatsoever. Just 1 minute, that's it. Thank you. We do all this, but do they really comply? How good is the compliance? Well, 20% of the patients are non-compliant. 50% may be taking the gluten inadvertently. So they are not clear, and they have taken things where gluten was present. And these patients have recurrent symptoms in many patients. Therefore, what is the real need is the need for non-dietary therapy. Do we have everything? No, not at all, but there are a number of drugs in the offing, and this drug, the liraglutide acetate, appears to be promising. This study on 352 patients appeared in Gastroenterology in June of this year. And what they showed, that there was a reduced intestinal permeability, reduced production of anti-TTG, improvement in symptoms in patients who were given this drug along with gluten-free diet. So the drug appears to be a useful adjunct to diet, but not a substitute to diet. So patients who are still having some symptoms or inadvertently consume intermittently, if they are on the drug, they will feel much better. So the challenge of chronic diarrhea friends is meticulous history taking and examination, achieve a specific diagnosis using the minimum number of tests. If a disease appears to be more likely, you can directly proceed to confirm it. If you think it is celiac disease, just do 1 or 2 tests, serology plus the endoscopy and biopsy. Increased awareness of celiac disease is required not only amongst clinicians but in general population at large, and once you have diagnosed, institute specific therapy. Thank you very much.